everyone, welcome. We are so excited to have Dr. Patty Stott with us today. She's going to be presenting on neurologic inflammation and complex chronic manifestations living with connective tissue disorders. So Patty has a background working as a physical therapist, but she goes much beyond the roles of a typical PT. She has a background that is very diverse that I will leave to her to give a bit more background on. So welcome. I hope you all can take in as much knowledge as you can today, because we are certainly in the presence of a master. Come on in.
All right, hey guys, thanks for coming. Before we start, I think just because I can't see all of you perfectly, we're going to save questions until the break because I do want to make sure that we answer them and I don't want to miss them if you guys have them come up. But thank you for having me. The first half of the morning, and I know we're running late, but I appreciate all the setup tolerance that everybody had. For those that maybe are a little bit cross-eyed at what I'm about to talk about, it's less time for me to talk in the morning, so I'll try to get to the important parts. I know that we have mostly rehab professionals, and at first what I'm talking about might seem like, why do I need to know all of this? And hopefully, as I go through what inflammation does to connective tissue, you all understand how important this is, especially for us that put our hands on people. And when we get to a certain point, and a certain area of inflammation for connective tissue, there's different ways to work on it than the standard of care in physical therapy. So, but we're gonna go beyond physical therapy, and it's really important just because I think we see so many of these patients, and by these patients, I mean connective tissue differences. And that's why I don't necessarily focus on just HSD or EDS, Hypermobility Spectrum Disorder, or Ehlers-Danlos Syndrome. And hopefully, as I talk through this morning, you'll kind of learn why I don't really label things anymore in this population. And today, this morning, we're going to spend time talking about the changes that inflammation has on extracellular matrix and why that might be important if somebody has a connective tissue disorder. So we're going to talk a little bit about neurological inflammation and the matrix itself and why it's so important. And then the second half of the morning, we're going to talk about COVID, because everybody always asks about COVID, and I said, okay, I'll talk about COVID. But through this morning, I hope that you realize it's not just COVID, but COVID is not nice to connective tissue. And then in the afternoon, we'll have some fun, and we'll play around with bodies, and we'll take a look at what's going on. But for me coming in, what I wanted to do, especially this first time coming in, because I have so much that we're working on right now, I wanted to drip a little bit in little pieces so that I left you all with a little bit of what we've been working on. And Amy Morris was nice enough to come out today for the afternoon, who we're working on abdominal compressions. So we're going to have a lab on that, and then we're going to have a lab on upper cervical instability, where I'm going to take you through some things, but feel free to ask questions about treatment strategies and things like that. So we have a full diverse day is really what it is, but hopefully through that day you'll understand that managing care in complex conditions is really individualized to their story. All right, so a bit about me, and this is like, it's important and it's not, right, because I'm an N of one. But I do have all of the things that we have in this population. I have EDS, but I don't have a diagnosis yet because I have a plethora of collagen variants. So take your pick. It's a wide variety, and we'll talk a little bit about especially collagen type 4 for those that are interested in genetics, and I hope you are after this talk too, because it depends on what type of tissue we're talking about, that the collagen or proteoglycans and things like that might be involved. I do have MCAS. I have one of the genes that was recently linked with HEDS and MCAS. I have POTS, but I also have the autosomal recessive inherited hereditary sensory and autonomic neuropathy. So I've got all of it. I tell people that I've won the genetic lottery for my profession and not my personal life. So I've really had a good amount of time to experience all of this and really wonder how I got there. Because if I was born with all of this, why did I seem okay until my 20s and then okay-ish until very much not in my 40s? So that's what I'm hoping to explain to you today is what are those things that are affecting our connective tissue more so than what we're born with. I like people to be empowered by their genetics, not to feel like they're defined by it. I do have a background in orthopedics. I've been practicing as a physical therapist for over 20 years, and I think I was with a surgical practice for about 15 years. I love the place, but something said I needed to move, so I did, and I started seeing more individuals with symptomatic hypermobility because they came to me because I had it, and they trusted that we could at least have a conversation, that I might understand some of the things. And the more that I saw in the hypermobility spectrum and not just a focus on orthopedics, the more I was getting weird stories that were coming to me, pseudotumor cerebri, and these years ago before we knew that pressure issues were a thing. And I thought that was weird, right? And how could it not be connected to connective tissue? I really felt like they were all connected. And then I went through my own personal health journey and really ending up with pretty much every neurological diagnosis that we have in the neurological phenotype, which we'll touch a little bit on. And I thought it was weird because I thought I was indestructible and healthy. Like I would do crazy things with my body. So I left orthopedics per se, although I treat orthopedics, and I've really gone down this rabbit hole of the other tissues in the body. Okay, and I do have a little stint in pediatrics and early intervention as well. But I've gone into this fascial counterstrain, visceral, neural, and vascular manipulation and touching the other tissues of the body. And hopefully today you'll realize why that is actually so important for some and can actually really play a role in orthopedic conditions or what we think are orthopedic conditions in this population. To make things more complicated, I still wanted to know all the whys, so I went back to school for functional medicine, herbalism, and I'm currently in my PhD program for integrative medicine. I really, from a cellular level, rather than giving somebody a diagnosis, I'd rather know why they had that label of a diagnosis. So that's really my journey. Again, about 7 years ago, I started only seeing patients with connective tissue disorders. It's still just me in my practice. It's really hard to find people that actually truly specialize, especially in the stuff that I'm going to be talking about today. And with the interesting background that I have and being able to work on it maybe in a more natural type of way, rather than pharmaceuticals and things which are totally appropriate for some people. But I don't even know how long it takes to get into my office. All I know is when my schedule opens, within 2 minutes, however appointments I have are taken. I've been told that it's easier to get into a Taylor Swift concert than to snag a cancellation on my list. So we need more providers that understand what I'm about to talk about today, okay? I do work with the EDS Society. I work with a couple of their different programs, Global Learning Conference, and I work with the Allied Health Professionals Group. And if some of you have not signed up for that as an allied health professional, I have found it so valuable in learning as well, even at what I think my level is. There's always things that we don't know, and when people bring questions, it really helps us grow. And I have courses out there for MedBridge and Home CEU. We're working actually on some advanced courses for MedBridge that are hopefully coming out at the end of the year on these abdominal compressions and then upper cervical, advanced, and cranial presentations, so more complex patients. And then I have some books and publications that are out there. One for physical therapists that we just had come out. We're working on volume 2, and then I'm finishing up my medical memoir that kind of explains a little bit more about what we're talking about today in a more personalized way. And then most importantly, I'm always so excited when other people want to learn about connective tissue. So thank you all for coming today. I kind of went through this already, what we're going to be doing throughout the day. But I want to hang on to you guys in the morning because I know when I talk about extracellular matrix, I might get excited, but maybe other people don't get as excited as I do. So I'm going to give you all a little spoiler alert, is that the problem that we're seeing in a lot of these patients that have what look like a progressive connective tissue disorder or systemic manifestations or neurological phenotype actually are probably presenting with extracellular matrix stiffness and not hypermobility, as we tend to get hyper-focused in. So hopefully some of you get more interested in what I'm going to say. So we're going to talk about extracellular matrix dysfunction within connective tissue disorders. And what that really means, we're going to define it, talk about the neurological inflammation in this first part. And then we'll take it through a viral lens too. So I'm going to redefine what a connective tissue disorder is. I really appreciate the fact that we talk about hypermobility because that is a clinical sign that somebody might have a connective tissue disorder. So it waves a little flag for us that in this individual, we might want to be concerned and screen for some other things. But a connective tissue disorder means that somebody has an alteration in their 3D structure of connective tissue, typically, or something that can more likely influence that structure. Okay, so kind of the chicken or the egg conversation that we're having with genetics right now. There's also other components of the extracellular matrix outside of collagen that can be involved. I know that we get hyper-focused on collagen, but if it were that simple, I think we would have found HEDS already. So there are other things out there that can affect the 3D structure, which is what we're going to talk about, and then why the 3D structure is so important to really chronic health conditions in general, but especially for our population that might be more at risk because they were born with something a little bit different. So this is from the EDS Society. Just a reminder that it's not all just collagen. Okay, so yes, we have collagen type 1 and 3 and 5 that are implicated in some of these, but if you look down here, these are other genetics that influence the extracellular matrix in a different way. So again, step back from collagen for a moment. It's important, and it's really important if somebody has it, but when I get somebody's genetics back, and we'll get to these really cool slides of, you know, what the different ratios of these things are in our different tissue, I'm more concerned with what is your collagen, or, you know, what are your other genetics, MTHFR, kallikrein, what might it be, and then how will that play a role when we add inflammation into your system. So connective tissue is everywhere in the body. I'm hoping that everybody knows that, and especially seeing these patients, like it's the GI system, even the neurological system. It does so much for the body. It packages and compartmentalizes, so it helps with structure and function. The one that we're going to talk about a lot today is this protection, defense, and repair, and that's what we're going to define, because this is where things can actually basically become dysregulated and fall out of homeostasis for the individual. Insulation, I'm not going to go down my rabbit hole, but if anybody wants to stop me at any point and talk about fat cells and the fact that they're actually immune cells, so when our patients have weight management problems, we might want to think immune system as well, especially if they're doing all the right things. And then transportation, so blood's a connective tissue. We'll talk a little bit about the vascular component as well with connective tissue disorders. So it's not just ligaments and tendons. I think, again, that's a good clinical sign that we should be looking for, but it's so much more in the body. But we'll still run through it. So there's connective tissue proper, so we have loose connective tissue, right, which is kind of the stuff that surrounds blood vessels and nerves. And we'll talk when we go into COVID later why that's actually important, these barrier systems that are built in the body. And we have the reticular that's kind of around other organs, and it exists with different types of collagen that's in the body, and then our fat tissue. And then dense tissue is what we think about a lot. Right, so dense, regular, tendons, and ligaments. And then we have irregular, which is a lot of lining, different fascia in the body. But just to remind you, there's a lot of different things in the body that can be affected if somebody has a connective tissue disorder. And then cartilage, bone, lymphatic as well. So this is from Leslie Russick. She did a great job in putting together, this is pretty new, all of the symptoms that can pop up in different systems of the body. So if this were a tendon and ligament problem, this would look weird, okay? This is an extracellular matrix dysfunction, and that's why you can end up with so many things in so many different systems. I get excited when I see this. I don't know if anybody else does. And I do pull this out for patients and I show them. And I pull this up for myself when I'm thinking about patients too. When we talk about the extracellular matrix and why it's important, yes, collagen does play a role, but the extracellular matrix is kind of this space where things exist. And the things that are in that matrix, kind of like you're baking a recipe, the things that go into that bowl and the ratio of them, of your ingredients, is going to determine if you have scones, if you have muffins, or if you have cupcakes. So if somebody is born with sugar that's more like salt, then your recipe is going to taste very different. So this is a really nice article that goes through the composition of those connective tissues in the body. So you can see, if we look at articular cartilage, collagen type 12, 11, 9, and 5. So again, I just love having people's genetics, and I don't point fingers at any one thing, but again, it's just good to know that based on what they're complaining of, col type 1, that osteogenesis imperfecta crossover, we know there's a lot of collagen type 1 in bone. So I just pull this up over and over to be able to see, and you can see like decorins in there and ligaments, so we do have that. We have it in tendons as well, and we'll talk about it a little bit in the basement membranes too. But just really important to understand there's more than just collagen, and collagen is more than just collagen. There's different types as well. So again, it's this three-dimensional system, okay? It's kind of where everything comes together, and the ingredients that go into the recipe, what comes out of the bowl, is going to determine if we're looking at, you know, a gastric lining versus, you know, a vascular lining versus a ligament, okay? For those who are already excited about what I'm talking about, there's a book by Pishinger that was written in 2007 that is all about the extracellular matrix, and it's fantastic. I do think that if you specialize in connective tissue pathologies, you should understand everything in this book. It talks about chronic health ailments and how they can stem from this stasis and chronic inflammatory overload that happens in this space. But as he says, it is defined as a functional unit consisting of the capillary bed, vasculature, connective tissue cells, and the autonomic nerve endings. Okay, and what we'll talk about too is also immune cells and like literally everything else that happens at a cellular level in the body. So if that's what the extracellular matrix is, I have about 100 other slides that I'm not going to show you today on mast cell activation syndrome and autonomic nervous system dysfunction, because we're still talking about the same thing. When you add dysfunction, more dysfunction, like an inflammatory cascade that happens into altered connective tissue, you can end up with vascular issues, you can end up with autonomic issues, and you can end up with mast cell issues. Okay, so we're all talking about the same thing. We just have to come back to why is somebody's matrix dysfunctional? Is it just their genetics, or have other things happen to those genetics? Okay, and then there's other things too within the extracellular matrix. There's lots of things. I say it's like a swimming pool where you've thrown everything into that pool, but you should still be able to kind of swim and move around in it and bypass, you know, whether it's a pool noodle or a float toy. There are electrolytes, glycosaminoglycans, proteoglycans, glycoproteins, polysaccharides, collagen, elastin, and other proteins as well. So if we can't figure out why we can't find hypermobile EDS, it's because there's so much to look through in this person that can be affecting the function of their matrix. Right. I am going to kill some of these concepts a little bit so that hopefully we don't have to keep coming back to, there's a lot of different function in the matrix. It is not just the laxity of our ligaments and how it holds our body together. There's so much more, okay? So yes, in this dense connective tissue that we talk about, ligaments and tendons, collagen is the main structural component that stabilizes the extracellular matrix, okay? I say collagen, if we're talking about being in the city, this big skyscraper that you have, that steel reinforcement is your collagen, okay? You have people coming and going in and out of the building. Everybody's doing their job like they should. It's a regular, typical day. Now, if somebody has steel that's more made of rubber, you have a little bit of a collapse and you're going to run into some function problems on a normal daily basis with people trying to move through the building and trying to keep it from shifting and rocking. And then when you add more people that aren't supposed to be in that building, like pathogens and things like that, it really can bog up the whole rubber structure that's trying to hold things up. So we don't have the reinforced steel of the collagen that's holding up the 3D structure, okay? Proteoglycans actually also help line up those collagen fibrils, but in loose connective tissue, they help stabilize that tissue. So everything has its role. So again, the person in front of you, does it look like they have more of a loose connective or a dense connective tissue? And then we might be able to figure out how we can help, especially whether it's manual work or working on systemic inflammatory load. And then depending on the density of the connective tissue, and this is important because now we're talking about physiological versus pathological, which is what we get into later on. When we have a physiological state, we have the appropriate tensile strength to hold things up. We have normalized cellular adhesion that happens on a cellular level through that matrix. We have a normalized reaction to chemical stimulus that happens. And we have normal cell migration. Like I said, it's kind of swimming through that pool that's got a lot of stuff in it, but we can get through that pool. We can still get there. And then it helps facilitate tissue development and healing because we can get everything where it needs to go for the proper role of homeostasis, right? This extracellular matrix is constantly dynamic and moving, and it should be. So it is malleable. It should be malleable. Once it becomes stiff, which we'll talk about, now we're not actually getting the cell migration, the cell communication that we should. But it should be malleable. We should have inflammatory mediators come in, do their thing, and then be able to leave that area. So this is just kind of reiteration of the things that we've already talked about, but again, I'm going to drill it over and over because of how important this is. Cellular migration happens here. Things move in and out of the matrix. It helps the cells regulate, respond to stimulus, so it basically helps with receptors and sending messages out, cell nutrition. And this is important, what we're going to talk about, especially the viral load today. Through this working together in a balanced way, it eliminates the waste of products and toxins from the extracellular matrix. The way I explain this to patients is you have a faulty filter. So this acts as like the filter for the body where things come in, you're supposed to take care of them and push them out. And if somebody is built with a filter that those little fibrils that are supposed to be cleaning things out aren't as structurally firm as they should, then we're going to have a different process of cleaning out pathogens. And this is where we see the progression of connective tissue disorders. Yes, metabolite and toxin accumulation. It acts as a buffer to stresses, and we'll kind of have some visuals on this. I mean all stressors to the human body because it's transmitted through the extracellular matrix, and that includes physical, chemical, biologic, electromagnetic, and psychological. And don't worry, I'm not going to go down all those rabbit holes, but if anybody wants to pull me aside and ask about any of them, those are my specialties, are basically toxins added to the matrix, and how do we help those? Lots of things are talking to each other, and I have this one up there just so that we see, oh, inflammation is the problem. This is what really can get caught in that self-perpetuating cycle of inflammation, and if some of these sound familiar with people that you've worked with, prostaglandins, which we talk about mast cell-related activity, cytokines, lymphokines, neuropeptides, proteases, all of these are actually what are supposed to be working efficiently within the matrix, doing their job, and then turning off when they're supposed to. Okay, so homeostasis, malleable, constantly dynamic, is what we're supposed to be seeing in this matrix for healthy connective tissue and system activity. Okay, so that you didn't have to listen to me talk all the time, I'm a visual person. So I threw up a bunch of visuals so you can kind of see what this looks like. It's like somebody threw a bunch of stuff into the pool. Okay, there's a lot of stuff that happens in this matrix, and I think this is why it's so difficult to figure out, why does somebody not feel well when they have a connective tissue disorder? Why is somebody having these seizures that don't seem to be something that we can put a diagnostic label on? Well, here's the perineuronal nets, which we're going to talk about. So the extracellular matrix is responsible for translating to the systems of the body if we're in homeostasis or not. And we'll talk a little bit more about the neurological inflammation because that's near and dear to my heart in my practice. It's primarily what I work with is neurological presentations now. Okay, so lots of things happening in here, and we are going to talk about those little alien guys. They're my favorite, those little microglia cells. We'll talk a little bit about astrocytes. Okay, we talk a lot about mast cells. I want to change the conversation to astrocytes and microglia. The information is coming out within the general population that we know that these are connected to neurodegenerative disorders, and we're seeing it in our population too because the extracellular matrix dictates what those guys are doing. Okay. Another visual so that you can see, and we're going to bring this back up again when we talk about COVID. So this is actually, I call it like the simple view of what we might be looking at if we're talking about layers of what's happening. So the extracellular matrix is like this free space, and it's not necessarily a tendon or a ligament, but the systemic piece of it, we have this interstitial matrix in the middle. So in that middle space, that we have those things kind of floating around. When we're talking about what it's made of collagens type 1, 2, 3, 5, and 11. Okay, the pericellular matrix, this is more of a buffer zone for taking on mechanical stimulus, and that's collagens type 7, 6, and 9, and proteoglycans and laminin. Okay, the basement membrane, which I think is a fascinating area, and this is where things move through, okay, is collagens type 4, 7, proteoglycans, and laminin. From my understanding, collagen type 4 is considered a kidney problem. Okay? I think knowing if we have a problem with what's passing through our membranes because of the structure of that membrane. And we'll talk about what happens when you add viruses, especially, or inflammation to that structure. It breaks down. So collagen types 4 and 7, I'm just curious, what sort of role does that play in our neurological phenotype when we start talking about the blood-brain barrier? Okay, so I've been looking at everybody's collagen type 4 that's gone to get their whole genome sequenced. Does it mean anything to me rather than treating them for what they're potentially showing as their inflammatory reason? No, it doesn't change anything, but I might teach them that, okay, if you get a virus and it looks pretty acute and you've had bad reactions in the past, then you are going to be the person that goes to your doctor for an antiviral treatment. Okay, that's what modern medicine is for. The other stuff we might be able to treat in a more holistic way. So I find that fascinating. Another visual, I really like this. So functional on the left-hand side, dysfunctional on the right-hand side. This is COVID. So this is COVID, and this is down at the lung tissue, okay? So you can see you might look at this and say, what's the difference? Because there's already a lot going on in that extracellular matrix. And I'm going to bring up a little analogy so you guys have a visual as to what the difference is. So on the left-hand side is like what I consider Olympic level synchronized swimming. There is a lot of stuff going on. There's a lot of people involved. There's a lot of stuff happening beneath the water, but they put together a wonderful performance, right? And then when they're done, they're done. That's the left-hand side. The right-hand side is my cross-country team on Tuesday. Okay, so on Tuesday, we had supposed to be outdoor practice and we had lightning. Okay, so our cross-country team ended up in the gym with volleyball and soccer, and it's middle school. Okay, so they kept the volleyball nets up. They pulled down the basketball nets. We had 6 basketball nets. We had a volleyball net in the middle. They pulled out hula hoops, beach balls, kick balls, and those scooters that are now not squares, they're triangles. And they said, have fun. That's the right-hand side. There's people screaming just to scream because you can hear your echo in the gym, but that's the right-hand side. We now have the stuff that we're supposed to be using in sport, but it's being used in a very dysfunctional way. Okay, so you can see if you actually look at some of the things that are written in here, and we'll talk about MMPs and why they're so important to extracellular matrix. But they're being released. We actually don't want too many MMPs within this space. Okay, you can see collagen degradation, which is really important if you have a collagen problem, right? So this is where if we add inflammation and we cannot find balance, see that little unbalanced sign up there, then it's going to remain in a disordered state. Okay, it will always be lightning strikes on a Tuesday and we're all in the middle school gym together and it's a fiasco. All right, a little bit about the fascia. So I'm not sure really who gets into the EDS and all the new research and things like this. This is a little bit parallel to what I'm talking about, but so important because we don't really talk about this extracellular matrix stiffness, but we're talking about fascial stiffness is the real problem with people with connective tissue disorders. So Dr. Tina Wang out in California has been researching fascia for some time. And the first look, not her first look, but the publication back in 2021, so a few years ago, she noticed the fascia is different in EDS. That when people have pain in the general population and people have pain in EDS, the fascial response is different. The muscle response is different on top. It tends to be more of a deep fascial response that we're seeing in HEDS when inflammation is added. So also it might be why it's difficult to find these areas manually on these patients if they are experiencing more of a matrix stiffness, because it is interstitial stasis that is the problem. Okay. Then she went on to look at people that had pain in their iliotibial band and found that there is stasis that happens. There's stiffness between the tissues. So again, if I can bring your minds away from hypermobility and bring it to the fact that somebody has hypermobility, and gosh, when you add fascial stiffness to that, now you can be pulling things out of alignment. Okay, now you can be causing chronic pain. So in many of our individuals that aren't responding to normalized treatment that we think that they should have a good response to, it actually might be a stasis problem that's happening between the tissues and not a hypermobility problem, okay? And does this happen elsewhere? And that's what we're going to talk about today, because the research is out there for the general population, and it hasn't transferred it over to people that might have alterations in the extracellular matrix. So we're going to do that a little bit today. We're going to get into neurology a little bit because we have to, right? I think that our biggest unserved population is the neurological phenotype of HEDS, this group. And I think if we just understand that this is a breakdown problem in the matrix, then we can start to treat them a lot better. The brain has its own extracellular matrix, so it has its interstitial space. It is collagen and other components that are in it, just like other recipes that are in the body, different ingredients. And it might be more compromised with HSD and EDS. And we're seeing this more so in some of the research that's coming out. I don't have lab preferences, I just appreciate all the research. But you'll see, like the Norris lab has shifted their language to extracellular matrix a little bit more, right? And if you look at some of the work that they've collaborated with, you'll see that there are, we'll bring it up later in the CSF leak article, blood-brain barrier disruption that happens. So we can't forget that it's not just ligaments and tendons, it could be different barrier systems, like what's supposed to be protecting our neurological tissue, that things might be getting into more easier or put somebody more at risk that has an alteration in their connective tissue. Regarding the stiffness, the interstitial stiffness that's happening, could we be seeing this happen in other areas of the body? And we're going to correlate that with COVID, yes. There's not a whole lot on the stiffness aspect in regards to the neurological piece, so we're really going to break that down today to talk about this difficulty draining and filtering in the neurological space. For those that I've chatted with that play with tethered cord in the clinic, it is a neurovascular plumbing problem, okay? So inflammation, and we can't get it out, and we can't stabilize it, and we have stasis at these neurovascular structures. So that's why things like fascial counterstrain and anything that works on the dural vein drainage or things that work on like spinal lymphatics that are in that area are temporarily relieving some symptoms for patients, is because we're improving plumbing. So neuraxial dysfunction, I know everybody read this when it came out just a few months ago. It's a wonderful article. It goes through the neurological system in those with connective tissue disorders and why altered neurological tissue can lead to dysfunction. This one really talks about the mechanical load of it, but I think that's so important. When people are saying, look, I know that I have the systemic inflammation, but I do have upper cervical instability. We see that a lot, right? Well, we have to remember that if inflammation is added to an extracellular matrix dysfunction at the level of neurological tissue, and we know that that tissue moves differently, it's still going to be a layered process on what we need to work on, even for upper cervical instability. So we have to make sure, especially with the meningeal response that we have that associates with the immune system, we have to make sure that we're working on inflammation literally with everything that appears chronic in these individuals. And again, give you guys some visuals so your brain can turn off just for a bit. This is why I love this paper too. So your neuraxial interactions, your physiological state on the left, and then what happens pathologically in this population because mechanical forces change because of, yes, the ligament part of it, but also probably some of this neurovascular irritation that's happening too. Okay. So I like to tell people I'm not going to offer you my opinion. That's actually very little in this population. I can offer you what I've seen over and over in the clinic. I can offer you what's out in the research. This I don't see yet, so I'm just going to say it. It's more than a ligament issue, it's a filter issue. Okay, this is a pathogen problem for a lot of people, especially the neurological component. More things are getting into our filters, okay? We have more individuals that look like they have connective tissue disorders. And I hope as we go through the inflammatory process of what happens at the matrix, you all understand. I'm going to talk about COVID, but Epstein-Barr, mold exposures, the electromagnetic frequencies for some, and really there's genetic components that also influence your reactions to that as well. But physical stress, emotional stress, all of these things feed into that same matrix, and where we're supposed to be controlling inflammation, and we might not do a great job at it. So this is my opinion. We are seeing more people that look like they have a connective tissue disorder, not because we're trying to slap labels on people, but because people's extracellular matrix is getting dirtier, and we don't really have a good strategy to help them filter it out and clean it out yet. So as I talked about a little bit before, now we're going to go down the stiffness rabbit hole. For a lot of these individuals that are starting to look like progressive cases of systemic connective tissue pathologies, we're dealing with a stiffness problem. And we know that extracellular matrix stiffness is associated with chronic disease and chronic disorders. We know that already, okay? Extracellular matrix stiffness is caused by inflammatory reactions in the interstitial spaces, so that in-between space where everything's supposed to be moving freely, okay, with collagens type 1, 2, 3, 5, and 11. All right, or dysfunction at, remember I said that membrane level is super interesting to me. Collagens type 4 and 7. All right, this is not from an article talking about connective tissue disorders. This is talking about the general population. So again, if we understand if somebody already has a problem with collagen type 1, collagen type 5, that we might be seeing a problem in their ability to not develop stiffness in that area, okay? Those that have an altered extracellular matrix structure, they might be more prone to the stiffness developing, right, because of genetics, because we're already seeing it in the fascia as well and the neuraxial dysfunctions, okay? So stiffness seems to be a problem. Hypermobility is a sign. Blood-brain barrier issues, I love talking about this, so I've only put a few slides so I don't bore you all with my talk on neurological inflammation. You could go on all day about this. But the disruption to the blood-brain barrier is a common trigger for astrocytes and microglia to come into that space, right? So I'm hoping by the end of this, you all now remember astrocytes and microglia. They are much more of a hot topic as we're talking about these neurodegenerative conditions that have quite a significant overlap with our neurological phenotype, right? Cognitive dysfunction, how many people have been tested for MS and then told that they didn't have it, what the heck is going on? Well, it could be astrocyte and microglia dysfunction because things are breaking through the barrier that shouldn't be touching that neurological tissue. When we have repeated challenges or stressors to those structures, we can end up with what they used to call glial scarring, but that's not exactly what's happening, so they called it border formation. I think glial scarring is a lot easier for people to envision, but it's not really that, you're right. And then you lose malleability. We're supposed to have this constant dynamic interaction, right? And we saw that little picture where the perineuronal networks are talking to the extracellular matrix. We lose the malleability to stabilize that perineural network, okay, the perineuronal network, which has to do with hyperexcitability of neurons and can lead to seizure-like activity or neurodegeneration. And again, all of the information is coming in from the health of the extracellular matrix or things are crossing through it. Any sort of brain or spine injury can actually cause glial scarring or border formation at the neural tissue. And we know with our population that there seems to be more of an adverse response to even lighter concussions and things like that. So we know that we have a change in the dural response at this extracellular matrix. So we might be more likely to see glial scarring or these adhesive type reactions within this population. Okay, I promise I'm not going to go down. I have hours and hours I could talk about astrocytes and microglia, but we're not going to. But it is important that astrocytes are really like a neuroimmune cell. So they do attract immune and inflammatory responses to help deal with a pathology. This is where there's a book called The Angel and the Assassin, and I think that's a perfect description for astrocytes, like we talk about mast cells too. They are physiological until they're not. And that's the same for astrocytes as well, right? They don't directly synthesize the perineuronal networks, but they're going to regulate basically how they function through their interaction across that membrane and what they're relaying the health of the interstitial matrix is. For those who do like a little bit more nerdy, there's different types of astrocytes that are out there. When we're talking about transmission, so basically like if we're talking about hyperexcitability or neurodegeneration that's happening, those protoplasmic astrocytes more modulate the transmissions that are happening, and the fibrous astrocytes have more of that supportive structural role in the body. With border formation problems, so we have this, it was supposed to be a protective sheath of inflammatory responses that happen around neural tissue to protect it. It's going to disrupt, again, basically the synaptic transmission, the communication within the neurological system, okay? It can determine the excitability of neurons. They also did link it to basically pain responses in those that have spinal cord type of injuries. So we know that it's not just brain, this is other areas of the body too, but again, with the perineuronal network, this is associated with seizure-like activity. So seizure-like activity can be the same conversation of what we're about to talk about in a little bit, of this overdrive of inflammatory reactions that are happening and now breaking into the neurological tissue. They're caught in a self-perpetuating cycle of inflammation. They can't break out of it. And in that particular person, it is disrupting their perineuronal network. Okay? So again, if we work on the inflammatory pieces, we might be able to help them. I'm throwing MMP9s in here because we're going to talk about them in a little bit when we talk about viral components. They do appear to be, MMP2 and 9 really talk to the neurological system. Okay? They do seem to be a major reason for perineuronal network disruptions. Okay? MMPs are matrix metalloproteinases, and they actually break down the matrix, the structural component of the matrix, which is why we bring it up with COVID later on. Okay, it is MMP2 plays a role, but MMP9 is the most widely implicated of those matrix metalloproteinases within the central nervous system for maintaining homeostasis. Okay, so we're just going to link this all together a little bit later in understanding that physiological to pathological switch that happens. All right, and for those of you that put hands on brains, which I'm hoping some of you know, you can actually manually manipulate brains. I love doing it, it's amazing. It really helps kind of settle this down, doesn't cure, but it can help settle it down. But for those that keep tuning into the brains of individuals that have this neurological inflammation and keep getting drawn to the hippocampus over and over, the plasticity might change and it might feel dense under your hands, because we're talking about a stiffness problem. So if neurological tissue, for those that are trained in sensing neurological tissue and parts of the brain are feeling densities, stickiness, density, it might be more of a stiffness problem. And I know everybody's up to date on their research. Actually, this is from a while ago. Enhanced expression of MMP9 was found in those with HSD and HEDS. So we know that these individuals are having a problem with homeostasis in the neurological system. For some reason, it doesn't tell us why, but there are links. And so this is actually not related to connective tissue disorders. Again, general population, this information is out there. So I circled these just so that you guys could see what are we talking about in our population. Well, we're talking about them already having possibly a shift in blood-brain barrier permeability. Okay, what that can lead to through all of this stuff, that reactive astrogliosis or overabundance of astrocytes, it can lead to epilepsy, neurodegeneration, demyelination, and astrocyte degeneration, which is kind of what we see in this neurological population. I love this little graphic because over there it just says resolution, healthy brain. Easy, right? So easy. It is not that easy. Just another visual so that you can see when we're talking about astrocyte dysfunction, this is important because we're talking about the role of the neurological inflammatory piece. And if we have this overabundance of astrocytes and the astrocytes become dysfunctional, just some things to point out. We have that pathological remodeling. Okay, so you can have remodeling of the tissue itself. And again, we see so many crossovers with this population of the movement activity that they have, this, Huntington's disease, ALS, we have Alzheimer's, epilepsy type activity. All of this is such a crossover. And then we can have these severe scar forming that they have listed as trauma and stroke because we're talking about the general population, but perhaps in our population, we might be talking about tethered cord or Chiari malformation. Okay, so a little bit more about border formation because I want you to see the overlap with Chiari malformation and tethered cord. Okay, I think this is really important, and it's very important to understand this piece when we're considering surgery for an individual and how to prevent retethering or the symptoms of that from happening. But what we have, so at the injury site neurologically, you do have astrocytes that come in to try to protect the area. Okay, so it forms this area of connective tissue with microglia, macrophages, meningeal cells, and fibroblasts. So it's like a Band-Aid. It tries to form this Band-Aid around the area. It can occur at the level of the brain and the spinal cord. So think tethered cord and think Chiari malformation. And, it can be other things as well, like arachnoiditis and other spots for people. And these lesions, so in the general population, these lesions can be from trauma, infection, or autoimmune conditions. And for those that are following the EDS Society, you know that a lot of funding is going into the overlap of autoimmune conditions and EDS. And I think, hopefully after today, you'll understand why. So with glial scarring, again, we have that hypertrophy that happens within the bodies of the astrocytes. I do think I have a little picture for you so that you can see that. They kind of puff up. Okay, they get little chubby little astrocytes when they're supposed to be these smaller little things that move freely through the body. The mechanical trauma will cause those two different types of astrocytes I was talking about, so the structural ones and then the ones that talk with synapses, to thicken their bodies, okay? And again, for those with hands-on neurological tissue, it can do this twice as fast in the hippocampus, okay? The cortical astrocyte changes might be what's related to seizure-like activity, so for just those that are trying to connect dots, that's where they might be located. And they can, this is what I show people actually of the picture that I hope I have on here in a moment. When the morphology of the astrocyte changes and it puffs up, and you think about what people say with tethered cord, you're like, oh, that makes sense. That's exactly what I feel like. The space that I had for my cord and my tissue is now full, okay? And it feels like it's adhered in place. And this is what it looks like. Not really, but just so that you have a schematic of what it looks like. So I also show this to people if anybody wants to use this article. It's great to just have them see what's actually happening. In the center, you have this non-neural lesion. So again, it's trying to protect the neurological tissue. It is connective tissue cells that are in there, okay? You have fibronectin, collagen, and laminin as well. So it's really this connective tissue protective layer that's being formed. It's protective, but everything around it is irritated. So again, if you don't remove the trigger that's causing the inflammation in that area, this will stay, and so will the astrocyte layer that's formed around it that's still irritated, and then the area around that that's constantly reacting to its inflamed environment. Okay. So tethered cord, we know through the research, through biopsies, this is a neuroimmune problem. Okay, they find abnormal mast cell counts, glial cells, and leukocytes. Okay, it's a neuroimmune problem. So it seems kind of like this border formation that's happening, or at least part of this inflammatory process of neurological tissue that's stiffening, right? And for the people that are working on this plumbing issue, we're seeing temporary improvements, and some people it lasts a little bit longer. But that's because we're getting some of this reactive zone to clear out for that individual, okay? It might be from acute injury response. So I think this is important when somebody's like, well, that doesn't sound like what happened with me. That will always happen with every individual. That's why we can't say tethered cord only happens this way or this way or this way. I have had individuals where, and this is the bucket analogy, right? When we're talking about neurological inflammation, it's not one thing that's happened to the individual, it's their lifetime of stories that if they haven't had support and the stiffness has been developing, then if we add that acute trauma, like a story of somebody that was in the ER that had a lot of neurological symptoms and their leg was stuck and their leg was yanked out from underneath them and boom, they had tethered cord. It can be that, right? But you also have these stories of it just kind of developed. Now you do really need the inflammatory process, the neuroimmune process, and you can have this physical aspect, and that's why I say this might be what we're talking about with Chiari malformation, upper cervical instability, and tethered cord, because when we're talking about abnormal movement in the spinal cord, we know that this happens with our patients with hypermobility. We know that they have abnormal movement, especially up in the upper cervical spine. So could this chronic mechanical stress be a contributing factor over time for those that don't have a story of an accident or a stretch trauma? Yeah, but I usually find something, even if it's segmental instability chronically that's been developing for somebody, there's usually something there. So there's usually an anatomical piece along with the inflammation. That's why I don't want people to think that I'm saying tethered cord is only inflammatory in all cases. Most of the component is inflammatory, and you have to look at anatomy as well. And we know that there's an overlap of these conditions in the neurological phenotype of each EDS, which in the afternoon, I'll kind of show you what that looks like. But it's just interesting because when they looked at the EDS populations, they had this group of like 10 or 11% of people. But that 10 or 11% of people, more than half of them had Chiari malformation, tethered cord. Like, that's a lot. That's a lot for an 11% population. So those people are experiencing something very different with their neurological inflammation control. Okay, a note about Chiari malformation, because I know we're all like, oh, it's an inferior pull of the cerebellar tonsils through that space that it's supposed to be sitting above, and it causes pressure in that area. Yes, however, when they biopsied that tissue, they found arachnoid adhesions in almost everyone, okay, thickening of the tissue, webbing at the obex, tonsillar gliosis, adhesions that obstruct the foramen, and then dural scarring. And it sounds just like what we're talking about, right? So there is an inflammatory component to Chiari malformation that we can't forget when we're considering surgery or considering somebody that has tethered cord and low riding cerebellar tonsils, that the pressure problem might be a scarring problem. And we know that Chiari malformation is found more likely in those with EDS or cerebellar ectopia. Oh, here's my picture. So this is what I show people when I'm like, does your neural tissue feel like this? So on the left-hand side, you have normal physiological astrocytes. Look at all that space that they have in there. And then on the right-hand side, you have reactive astrogliosis. And this is what people feel like. Sometimes they can say it's like they're a marionette with strings that are too tight. They don't have access to the freedom of their neurological tissue. And part of it could be that that's because their neurological tissue is not free to move anymore. It's got these puffy little astrocytes that are inflaming and taking up that space. This is really important, and this is not the same article I'm going to talk about with COVID, but we're just kind of seeing the same things over and over. In most cases, the morphology returned to normal once the stimulus was removed. So if it's not just mechanical, and there's an inflammatory component, you will not get rid of this condition. Or what I say is put them into remission, right? Because we're not going to get rid of all the risk factors, but hopefully we can bring people into remission. So we'll talk about that with COVID too, because they are finding the same things. And I try to make some visuals myself. So this is what I see when I work with somebody that has a neurological inflammatory problem. If you have a blood-brain permeability shift that happens, which can happen for a number of different reasons, including chronic inflammation in the individual, in the general population, okay? But you also have genetic risk factors as well, all right? Inflammatory reactions, viruses, other pathogens, physical stress and trauma, emotional stress and trauma, mast cell dysfunction, anything that affects the immune system, astrocyte microglia dysfunction, which can be other genetics as well, and they all meet together in this self-perpetuating storm of neurological inflammation, which could be our neurological phenotype of EDS. Okay, so again, it's just the extracellular matrix at the level of the neurological tissue is not handling the stress load of the inflammation. And this, especially for our manual therapists, and I know there's an interest in craniosacral therapy out there, I just like to cross over and over to say, hey guys, we're seeing the same things in the literature. Like if we have this buildup of meningeal lymphatic dysfunction in the cranial space, it creates a self-perpetuating cycle that's not going to get stabilized until somebody works on the inflammation and starts to free up any adhesions that are in this meningeal tissue. Okay, so this was newer to 2025. So we're seeing, like, it's inflammatory problems, but it manifests differently. This is cranial lymphatics or glymphatics, right? We can talk about it in an individual as tethered cord. We can talk about it as seizure-like activity. It can manifest in a variety of different ways, but neurological inflammation and a faulty plumbing system is the issue that we're having. Okay, if your brain works like this, you'll be totally fine with EDS. Okay, totally fine. Does anybody know what this is? Oh. Okay, has anybody heard of the spiky leaky phenomenon? Oh my goodness. Okay. I'm going to rein it in so I don't spend another 3 hours talking about this. What I'm going to point out as the spiky leaky phenomenon that's happening in so many of our patients with pressure dysregulation is just the top left, environmental trigger. This study that said, hey, these patients all seem to be presenting very similarly, but with kind of different things, and they're having difficulty regulating pressures, and it doesn't really look like high, it doesn't really look like low, I can't tell what's going on. They seem to be hypermobile, and they all seem to have an environmental toxin exposure. So we're seeing it in people coming out with these stories, but this is actually great for manual therapists, believe it or not, because spiky leaky syndrome is the difficulty in managing pressures for an individual with EDS, okay? And this is really talking about the plumbing problems that we're having at the cranial-cervical joint or around this cranial base. So it can be all of these things. The way that I look at it is look at all the things that we can still look into with an individual, whether it be jaw dysfunction, position of the mandible while sleeping, position of the tongue ties, things like that, vascular compression and Ehlers syndrome. All of those can go into the presentation of Ehlers syndrome for an individual, or this spiky leaky. Just so you have the science behind it, it's this phases that individuals go through, especially when they go to sleep, is that they have this buildup of pressure because the plumbing is not great for whatever reason outside of the cranium, and they actually leak cerebrospinal fluid into the cranial nerves, and those people will have puffy faces in the morning and just feel pretty much not good all the time. Sleeping doesn't help, standing up during the day doesn't help, because during the day their body tries to re-regulate the pressure system, it doesn't work because it's got so much to catch up from. And if you build up enough of this seeping into the cranial nerves, eventually they can leak. Okay? So not necessarily a traditional spinal fluid leak that we're seeing, but this phase of waxing and waning of pressures that's really hard to stabilize, possibly because of a neurovascular plumbing problem. Okay? But it's great. Andrew Maxwell, it was written last year. Okay. And before break, though, does anybody have any questions so far? We're going to talk about COVID next, the viral component.
How do you determine, I guess, the consistency of someone's ECM? Is that like a test that you can run, or is that something that you check on an individual basis?
I don't have an answer for that. I looked into it when I read Pishinger's book probably about 3 years ago, and there wasn't any standard of way to test for the ECM. And I think it's really tough too, because we're talking about what structures are we talking about? What ECM component are we talking about? We're talking about the health of neurological tissue, we're talking about somebody's gut lining, what extracellular matrix? So I don't have an answer to that. Wouldn't that be cool if somebody worked on a test that could determine the health of the extracellular matrix in a certain area? But if you understand this whole homeostasis piece, when people come into me and they're like, oh my gosh, look at my blood test, what does this mean? And I'm like, inflammation. That's why, like, all of these alterations that you can have in so many different systems of the body can just come down to the fact that you aren't moving things cellularly like you should through those spaces, and you can have abnormal liver results or hormonal dysregulation and things like that. So, no, but if you'd like to work on that, that'd be great. Yeah.
Are you saying that the spiky leaky issue is coming from the combination of the mechanical differences because of the instability combined with the neurovascular inflammation, right?
Yes.
Okay.
Yes, and that's what, like, I don't want to point my finger. I love living in the world of inflammation because not enough people do, but you have to work on the anatomical structures as well. It would be really weird if somebody just had inflammation and had none of the mechanical features that would also increase the rate of blockage. Yeah.
Okay, so are you typically not seeing that in people who don't have some of the like cervical instabilities? Like, is this typically traveling with your cervical instability population?
Okay, so that's a great question. No, because cervicomedullary syndrome doesn't need instability to be present, and there's still dysfunction there. So that's why I say hypermobility is a key driving factor for a lot of the anatomical problems that we see. But if you have a stiffness or a plumbing problem from tissue tension, that can also disrupt that area too.
That makes sense, thank you.
Yeah.
How can you tell what kind of collagen variant you have? Like, is there like testing that needs to be done, and how common is that testing?
You might want to turn the camera off. So it's really tough, right? Because we think, oh, we can send this person to any geneticist, and that geneticist will obviously run a connective tissue panel. And that's not necessarily the case that I've seen. I have one person in Denver, thank goodness, that still takes insurance. Our other guy has a 4-year wait that runs the Invitae panel for connective tissue. So a lot of them are running the same connective tissue panel that's out there. I have a lot more people, like I said, collagen type 4 is not on Invitae as far as I'm aware. I have a lot more people that are opting to have their full genome sequenced. And that's why I say some geneticists might not like to hear that. And I don't think a lot of patients are ready to see what their full genome has to offer for them. So that's a really case-by-case basis, and who's running it and who's looking at it. There are companies that are certified. The geneticists are still arguing that they don't count. But it's the same certification that Invitae has. So there are ways to get it yourself through a consumer market now, and actually for a few $100s. Yeah. Mm-hmm. Any other questions?
I'm not a PT molecule person, but what is the tethering, like what is actually being tethered with the cord?
The phylum.
Oh,
The
okay.
phylum. And now the top recommended procedure is just to remove that whole phylum. Okay, good. So that's what, let's work on the inflammation first, because we don't know what that does to the transfer of forces up to the cervical spine.
Wow.
And it's working wonderfully. I just had somebody get the procedure done, and she's doing wonderful, but she also had underlying occult spina bifida, 9 accidents that caused a calcification to build up on that cord, and we couldn't find her anybody locally in Canada to be able to treat the manual components that she needed. So she's doing that's why I say surgery is appropriate for some people, but we have to exhaust, and she did. She exhausted all the inflammatory stuff, and they actually didn't find the mast cells and the astroglia, or the microglial cells within the tissue biopsy that they did with her. So it's pretty cool. She ended up being a regular tethered cord.
So the treatment cord.
For some people.
Okay.
So I can't guarantee, because everybody's story is so different.
Got it.
Yeah, I think that we can bring a lot of people into remission. But that change in connective tissue can still be threatened by things that happen in their future. But that's why we give them the tools to learn, okay, well, if these are the things that my body is more reactive to, what do I have for the future, whether it's mast cell stabilization, antiviral treatment, antibacterial, a detox, what is it that helps stabilize my tissue? I think so. Yeah. Yeah.
Sorry, I don't want to take up your whole break, but have you noticed any difference in those that have a sacral dimple marking present congenitally versus those who don't, that still go on to develop neural tension like tethered cord?
And that's on my slide for the afternoon. Do I see it in everybody? I don't. But in my cases that I'm leaning to have a surgical consult done with that amount of neurological tension, I do see that. I'll put it that way. There's people that don't have it and have the presentation of what looks like tethered cord, and we don't want to push them away. But I'd say for my more severe cases that we're considering going to see one of our specialists, that we might be looking for sacral dimpling as well. Yes. Yeah. Yeah. Okay. Time for a little break, everyone? Yeah. Okay, good, because we go into viruses next.